So ovulation induction is basically a pharmacological treatment. So what does it mean? It means induction. So like we do labor induction. What is induction? When the patient is not at all in labor, so we need to induce her. So that is induction. Similarly for ovulation induction. So in patient in which there is anovulation or when there is oligo ovulation, then we need to induce the ovulation in those patients. That is ovulation induction. And what is ovulation stimulation? Like if we compare it to labor, somewhat like we augment the labor when she's already in labor but the progress is not adequate, then we need to augment it. Similarly in ovulation stimulation, when she is on and off ovulating but every single cycle the ovulation is not perfect, the rate of growth of follicle is not correct, or the ovulation is not happening at the correct time, then we need to somewhat help her, है ना? So that is ovulation stimulation. We are getting the difference. Next slide. So this is the pathway of follicular genesis as we are aware of. We know there is primordial follicle which becomes the primary follicle, then becomes the secondary follicle, pre-antral follicle, small antral follicle, leading to the formation of the dominant follicle and which then ovulates. We are aware of this pathway. What is important here to remember is the first half is gonadotrophin independent phase, which is the intra-ovarian regulations. So this phase is dependent on number of parameters of which gonadotrophins, FSH and LH. Basically, these are the gonadotrophins that we'll talk of. So these are not dependent on them till the preantral stage. After the preantral stage, they acquire gonadotrophin responsiveness. So first they develop FSH dependence and then slowly they develop both FSH and LH dependence, right? And in after we have a dominant follicle, it's actually LH that is needed. So this is how this follicular stimulation and formation of follicles go. Next slide, please. Yes. So today we'll try and understand the concept of FSH window and FSH threshold. We'll not just read the definition below. We'll understand from this diagram which is given here. So what is FSH threshold? So this line is the threshold. This blue line, can you all see it here? This is the threshold. What does it mean? So below this level of FSH, the recruitment does not happen. What is the recruitment? Recruitment is the selection of a cohort of follicles or selection of one follicle to be formed as dominant follicle or the follicle chosen for ovulation. So till the FSH levels don't cross this blue line, the threshold, this recruitment does not happen. And it, so what happens physiologically is it crosses this line. That is when the selection of the cohort of follicle starts. By the peak, there is selection of one dominant follicle and then the FSH comes down. That is how we usually have monofollicular development. That is the development of a single follicle. So whenever we do any fertility treatment, say IVF, what is the idea behind? Or even not IVF, even when we are giving letrozole or when we are giving ovulation induction, ovarian stimulation cycle. So what is the idea behind? The idea behind is to extend this FSH window. This is the FSH window. FSH window is the duration, the time duration for which the level of FSH is above the threshold. कितनी ज्यादा समय तक वो अपने कट ऑफ के ऊपर है, जितने टाइम तक रहेगा उतना बड़ा विंडो है. So as we increase the FSH window, the more number of follicles can get recruited. So that is how we get a multifollicular development usually in these patients, or in which there's no ovulation. In them, we can at least start getting at least one follicle if we increase the FSH window. Is everyone clear with this concept of threshold and window?
Yeah.
This is a very basic concept we have to understand because all the physiology works according to this concept, right? Next slide, please. Yes, so we are aware of the two cell, two gonadotrophin theory. So what happens is we have this theca cell and the granulosa cell. Yeah, so this is the two cell, two gonadotrophin hypothesis in which there is the theca cell and the granulosa cell. So the theca cell has LH receptors via which the LH enters. The first thing which enters in the theca cell is cholesterol via the star gene, which gets converted to progesterone, and then it gets converted to the androgens. This androgen crosses the basement membrane and enters the granulosa cells. In the granulosa cells, this androgen is converted to estrogen via aromatase. So this aromatase is the enzyme on which letrozole acts. We are aware of this, right?
Mm.
So this is what they explain here. Now, next slide, please. Now we'll discuss about the WHO classification of anovulation. What are the classes? So there are these four basic classes we are aware. First is hypo, that is hypogonadotrophic hypogonadism, which means LH, FSH, gonadotrophins are low. That is how hypogonadism has happened. That is estrogen, progesterone, the hormones will also be low. Class 2 is normogonadotrophic, normoestrogenic, or hyperestrogenic anovulation, in which the LH and FSH are normal and the estrogen is either normal or hyper, which is causing this anovulation. Class 3 is hypergonadotrophic anovulation, hypergonadotrophic hypogonadism. That is basically it is ovarian failure. Ovarian failure, gonadal failure, I should say. So ovarian or gonadal failure has happened. So estrogen is not forming. So the negative feedback to reduce FSH is not coming. So the FSH levels will be very high, LH levels will be very high, and the estrogen levels will be low. This is hypergonadotrophic hypogonadism leading to anovulation. And the fourth is hyperprolactinemia. Right? Next slide. So, when do we need to undergo ovulation induction or ovarian stimulation? Induction when there is no natural ovulation, like PCOS or hypogonadotrophic hypogonadism, and ovarian stimulation when ovulation is happening but it is not up to the mark. We just need to augment ovulation, like in endometriosis, unexplained infertility, male factors, serodiscordant couples, DORs, these patients. Okay. Next slide. Yes, so this is the definition as per ASRM 2021 of infertility. So that is inability to conceive after, as we have been reading, 12 months of unprotected intercourse. But this is applicable only when the women is less than 35 years. When the women is more than 35 years, it has to be only for 6 months. However, there are conditions in which we have to intervene immediately the patient presents. We don't need to wait for 6 months. Those conditions are when there is some medical history leading to infertility, any history of chemoradiation or FMR1 gene mutation, any of these, we have to undertake them immediately for infertility evaluation. Right? Whenever we are doing infertility evaluation, the male partner has to be treated simultaneously. And for tubal patency, you have to do HSG or HyCoSy. And some additional test to confirm ovulation is usually not required when the patient is having regular periods. Why? Because if she's menstruating regularly, there is only 1 to 3% chance that she is having anovulation. There's more than 97% chance she is ovulating female. And then we have to go for ovarian reserve tests. So, what is the idea behind ovarian reserve test? Basically, it's not going to help in evaluation of infertility in these females, but rather the most important reason for ovarian reserve is it will help you to choose which treatment modality does the female need and how much less time does she has for procreation, for producing offsprings in her fertile journey. So this is the pre-treatment workup for OVI and IUI patients. We have to go for the endocrine status. The TSH should be done, prolactin should be done. These are two must tests. Tubal patency must be done, semen analysis must be done, and ovarian reserve also must be done. If all these are okay, then we have to go ahead with ovulation induction and intrauterine insemination. So these are the some routine tests which I have mentioned here for ovulation. These are the tests which can be used. Like we have to go for a menstrual history. If it is indeterminate or patient is not able to give the history, then we have to go for luteal progesterone, LH kits, and TVS. Then ovarian reserve tests need to be done like AMH, AFC, and baseline FSH and estradiol. For endocrine, it is TSH and prolactin. For the uterus, the cavity, the endometrial cavity, we have to do either 3D or the 4D ultrasonography, and we can also consider going for a hysteroscopy. And for fallopian tube patency, we can do either HSG or HyCoSy, right? So this picture is very beautiful. You can see this is a picture of a classical HSG picture, that is hysterosalpingography. We can see this is the uterine contour, the outline. These are the two tubes, and we can see the free peritoneal spill bilaterally. And this is a high COSY, hysterocontrast sonography. What we can see here, this is the uterus, the two tubes, and the spills which can be seen here in this image. For HSG, we use iodine-based dyes like miglumine ditrizoate, and for high COSY, we use SF6, that is sulfur hexafluoride, or we can also use ecovist, that is galactosin saline, right? So these are the different methods of ovulation induction. The first method, which is usually works in PCO women, is lifestyle modification and waste reduction. They can go for natural cycle and timed intercourse. Some drugs also help, like anti-estrogens like letrozole, clomiphene, or gonadotrophins like FSH injection or HMG injections, or CC plus CC or letrozole plus gonadotrophins can also be used. And in the worst cases, we may consider laparoscopic ovarian drilling, right?